Hello and welcome to our second Health on the Plains coffee hour of 2026. Today, and continuing on the third Wednesday of the month through October, I'll get to spend an hour with my cup of coffee and a great thought leader in the world of rural communities and rural health. Now we know this time doesn't work for everyone. So we will be recording this conversation, and if there's anything that really resonates with you today, we invite you to share it with your colleagues when that recap is posted. My name is Wyatt Beckman. I'm a senior analyst and portfolio strategist at the Kansas Health Institute, and I'm really thrilled to host this series. The Kansas Health Institute is a nonprofit, nonpartisan educational organization based in Topeka. We believe that evidence-based information, objective analysis, and civil dialogue can inform and support effective policies, programs, and interventions for healthier communities. This series is built on the idea that nuanced conversations with thoughtful people can help us better understand the many factors that shape rural health. And with that better understanding, we can all work to envision and implement more effective strategies and policies with and in our rural communities. So, how has the federal approach to rural health evolved over the years? It's a big question, and our guest today has been involved in rural health efforts at the federal level for more than 2 decades, and his name is Tom Morris. Tom serves as the Associate Administrator for Rural Health Policy in the Health Resources and Services Administration, or HRSA, of the U.S. Department of Health and Human Services, HHS. In that role, Tom oversees the work of the Federal Office of Rural Health Policy, often called FORP, if you hear that, which is charged with advising the HHS Secretary on rural health issues. The office has an annual budget of $418 million and administers a range of research and capacity building grant programs that serve rural communities. Tom has an undergraduate degree in journalism from the University of North Carolina at Chapel Hill and a master's in public administration with a concentration in community health from East Carolina University. He also earned a certificate in public leadership from the Brookings Institution in 2008. Tom, thanks so much for joining us.
Glad to be here.
So, as part of your job at FORP, and I've mentioned you've been there for several years, we could say many years, you get to travel all across the country. You get to go to events, you get to meet with folks. You have probably been in more hospitals for non-hospital things than just about anyone that's not a hospital employee. And I can imagine you've had your fair share of coffee along the way, and this is our coffee hour. So, do you have any memorable coffee experiences from one of your fort visits or events that you'd love to share as we get started on our coffee hour today?
Oh, well, sure. I mean, I'm not a true coffee addict like some of my friends, but I do remember one meeting where I mixed up the regular coffee and a decaf, and I got several cups of the decaf and just couldn't get awake. Just was still drowsy, and then I started getting a splitting headache because of the caffeine withdrawal. And it wasn't until about 11 a.m. that I realized the mistake I'd made, and by that time it was too late to stave off the effects. So I've learned to really pay attention to that little orange sort of tab that indicates decaf.
I hope you got your full strength today, and good reminder, and something we'll probably talk about in the context of rural work, that paying attention to the nuances and the little things of whether coffee has caffeine or not, and it can really make all the difference. So I I'm fortunate enough to have chatted with you at several occasions and know about the Federal Office of Rural Health Policy, or FORP. And it's been around for nearly 40 years. And you've been working at the office, as I mentioned, nearly 20 years. So you're really intimately familiar with what FORP does and where it sits within this broader federal rural health landscape. But for those who are listening in that may be less familiar, what is the Federal Office of Rural Health Policy? What is your role, and how is that evolved and shifted over the years?
Well, sure. The Federal Office of Rural Policy is kind of a unique entity within the U.S. Department of Health and Human Services. And I say that in the sense that um, we were created in 1987, I think because there was a concern that in our policymaking process, um, we were not necessarily taking into account the needs of rural communities. And so there was a sense by the Congress at the time that there needed to be somebody in HHS that was paying attention to rural issues. And so that ostensibly is why they created our office, just to make sure that the rural question gets asked at least. The other part is that once we got established, people realized that perhaps there were some grant programs and and other resources that could help rural communities. And so one of the things they asked us to do in our authorizing statute, what I mean by that is the law that created our office, was to also operate a national clearinghouse for rural health information to give people like a one-stop shop for where they could get information. Right now, that's the Rural Health Information Hub, but it's had several iterations along the almost 40 years of the office. But then they started really adding in grant programs. There was a sense that if we're going to do policy work at HHS and pay attention and review all the regulations with an eye towards how they affect rural hospitals, rural providers, access to care, availability of physicians and nurses, that we needed to have a policy function in the office. I mean, a research function in the office. And so one of our first programs was to create a research program that's still in existence today. The other thing that was one of the early programs was trying to get a state office of rural health established in all 50 states. There were a handful of state offices in rural health in the late 1980s, but it took till about the early 1990s before every state in the country had a state office of rural health. And so over the years, what's evolved is really they've added more and more grant programs to what we were doing. And I think the one common link in all of our grant programs is that they're really about, I think, enhancing capacity building. Some of our grants go to states, some of them go directly to communities, but they're all about capacity building. And they're also focused, I think, on access to care issues. Because that's the one fundamental issue I think that we all talk about in rural health is the challenges in terms of access to care. And so that's been the biggest thing is just the evolution of adding grant programs. And I think there's one really important notion that the Congress had in mind, which was if we had a suite of grant programs that were devoted to rural communities, it would mean that rural communities tend to be under-resourced. We're not necessarily competing against large urban areas. And so the thought that rural could compete against rural was appealing to those policymakers. And I think that's been a fundamental reason why they've sort of added to our portfolio over the years. And then the one final piece I think I'd add is there's a sort of the last provision in our statute that said they wanted us to work across government. And so we're here as a resource for anybody in HHS that wants to focus on rural. And you consider the breadth of HHS, NIH, Centers for Medicare and Medicaid Services, CDC, anybody that wants to focus on rural, we're willing to partner with and be a resource for. Because considering the needs of rural communities, it's not just, we're happy to have the 400 million we have in our budget, but we could spend all of that in Kansas and maybe move the dial a little bit. So if we could bring to bear the broader resources at HHS, that's where the real potential is.
Yeah, and you said at the beginning, I think it's something we'll keep coming back to. This I alluded to the rural question, and so maybe in more direct terms, how would you phrase what's the rural question that needed to be asked that we're trying to continue to ask?
I think it is what we're proposing, either in a policy or how we set up a program. Is it as applicable in a rural community as it is in an urban community? Would it work as well?
Hmm.
And if the answer is no, then we've got a problem.
Yeah.
And we're a very urban country, and so it's not a surprise that left to its own devices, we would devise programs that cover that 80% of the land mass and the 80% of the population that lives in rural America. And if you ask somebody, hey, if I told you you could devise a policy that works for 80% of the country, you'd feel pretty good about yourself. And the answer would be yes, unless you were the 20%. And rural is that 20%.
Yeah, that's helpful. And as I ask you about that question, and we are going to keep coming back to it. It's a reminder for me to let everyone listening in know you can ask questions as well. If you've got a question or a comment, please use the chat or the Q&A, and we'll we'll weave that into our conversation as we continue on. And there's lots of jumping off points from sort of thinking about what FORP is and what you all do. But one of the key roles that you touched on, and I think when maybe the folks that know of FORP think about front and center your role is administering grants and doing that capacity building work at the state, at local, even some national organizations that provide uh, support across the country. And last year, I was part of a team here at KHI. It was led by Shelby Rao, my colleague, and with Victoria Sterhov on the team. And we looked at FORP funding across the country over a 5 year period, and from 2019 to 2023. And I think one of my colleagues will drop the link to this for those that want to learn more or see all those resources. But something that really stood out among all the things was just the range of programs and initiatives you all support. There's funding for individual community hospitals, individual school districts, even local organizations. You mentioned funding for statewide offices, often state health departments, and there's those big research studies and research initiatives. And then there's those national organizations. So it's this really big range, even within what feels like you've already narrowed to rural health. Feels like we've narrowed, but there's still this huge breadth and range. So tell me, how do you all think about working across so many different things, and how do you think about prioritizing and adjusting to some of those shifts? Because there's, as you said, there's you could spend all the resources in one thing and it still might not be enough. So how do you think about that range and prioritizing within that?
Sure, it's a great question. And the first thing I just would really credit you all for the analysis you did. I think it's the first time anybody's really done it in the way you did it. And we've since pushed it out to a lot of folks as a way other states could sort of replicate your methodology. In fact, I was talking to the state rural health associations yesterday morning, and we mentioned your project there. But I mean, I think that if you look at the breadth of our programming, sort of two things are at work. One is that it does hang together as a whole, but these programs have been added over time. And I mentioned, first we had research on state offices of rural health, and so I think the Congress or the administration, depending on the time, has identified needs and said, hey, maybe the Federal Office of Rural Health Policy could do that. But when you think about the breadth of it, and if you're a rural community trying to navigate it, and how do we sort of think through it ourselves? I think it's kind of like when you work in a rural hospital or a rural clinic, you don't get to wear just one hat. And so it would make sense in my mind that we would have multiple offerings in the office that meets people where they are. And the other advantage we've had is the laws that have created many of our grant programs are really broad and they're really flexible. And those are not words that are normally associated with federal funding. But I really credit particularly the Senate Rural Health Caucus and the House Rural Health Coalition during the 1990s. They created a grant program called the Rural Health Outreach. And I thought the design was just so perfect. It basically says if you can improve access to care and or coordination of the care, then you're eligible for this grant. You got to be in a rural area and you've got to be able to do one of those two things. And what we found over the years is that there's a lot of activities that can fit through those qualifiers. And so I thought the design was excellent. The other thing I think that they were really smart about was they created them as startup grants. In other words, what can we do to give you some initial seed funding and then let the creativity of rural communities take over from there and really use that seed funding to perhaps get something started and then find a way to sustain it. And then the third thing I thought that was really smart in that design is that it wasn't a grant to one entity. You had to come together as a consortium of three separately owned entities. And I think this spoke to two things. One, there's more buy-in when you have to work across different groups. And in rural communities, you have to work with others because there's just not the economies of scale that are out there. So that orientation of the rural health outreach program is something we've carried through to just about every part of our funding, whether it's in the statute or not, as long as we're legally allowed to do that. And so that was really important as well. And so with that as a foundation, that has really sort of shaped the way the office approaches programs across the years. Because if you leave flexibility for communities, um, a new issue that comes up can be dealt with. And so, I'll give you an example. Um, there's a big push towards thinking about how we bring more value into healthcare. And to do that, you've got to be able to measure your quality. You've got to be able to produce savings. Well, you can do that within those two categories I mentioned, improve access or coordination of care. So even though in 1996, when the program was created, value-based care was not a term, by the time it was in the mid 2000s, we were able to use a lot of that funding for that as well. And it doesn't explicitly mention workforce, but a lot of people have used it for workforce. So, I think that flexibility is really important. And I think the idea of giving communities a broad way to leverage funding to meet their needs, as opposed to us sort of saying, typically what we do is, A is for asthma, D is for diabetes, and you got to do just these things. I think one of the hallmarks of that program and a way we approach a lot of the work we do is basically to let the communities decide within sort of these broad categories. I guess the other thing I'd point to is that we've really been lucky to have great support from several different administrations and from the Congress. And so we've been able to test out new ideas. I mentioned our authorizing statute that allows the office to be created. At the very bottom of it, there's a provision that says we can give grants to support healthcare issues in rural communities. So that's really broad. And we used that authority a couple of years ago because we realized how many rural communities were losing their obstetric unit in their hospital. And that was from research funded by our research center at the University of Minnesota. And so we had an idea, again, building on this consortium idea. What if we did a pilot where we allowed folks to come in and find ways to improve access to prenatal care, to sort of figure out ways that they can sustain obstetric care in rural communities, and sort of get at the risk factors associated with pregnancy that can really result in some challenging birth situations and have implications, downstream from that. And so from that, we came up with the Rural Maternal Obstetrics Management Strategies Program, or RMOMS. We always have to come up with very long titles that need acronyms. That's a federal requirement. But RMOMS, we tried it out as a pilot, and the Congress liked it so much, they then authorized it as a formal program. And so that's an example of where we had a research need, and we thought back to our early days with outreach about how we would provide flexibility to do that. And then we used our statutory authority to test out a new idea. The Congress liked it enough to keep it going. And so, to me, that's a perfect encapsulation of how we try to approach these things. But the reason we're able to do it is because of the model and the parameters that the Congress set for us so many years ago.
Yeah, that's a really great example. And an example of allowing one stream or one aspect of your work, the research to inform another aspect of your charge and the grant making. And something that I've always thought about is it has to be a key challenge when we think about federal work or even statewide programs is the challenge of building something that has some consistency in it that like you know what it will look like and how it will operate, but keeps the ability to be tailored to the unique needs of each community. You have your background in North Carolina or here in Kansas. There's a lot of similarities, but there's also differences. And it sounds like one of the ways you approach that is creating space for flexibility within these parameters. Tell me a little bit more about that sort of that challenge or that thinking of you building a program that you can get consistent evaluation or consistent measurements and implement consistently, but creates space to say it's going to look different here in Kansas than it does in North Carolina.
You bring up a really important issue in the sense that there's always this sort of dynamic tension between, if you're in a community, you want maximum flexibility, right? You want to just, I know what to do, give me the money, and I will make good things happen. And I believe that largely to be true. At the same time, we've got a responsibility to taxpayers to make sure that the way we spend the money is actually having an impact. And so you have this tension between wanting to give people flexibility, but then having some way to measure the impact. And the ironic part, as I mentioned, those outreach grants, again, the beauty of them is their flexibility. It makes them very hard to measure.
Mhm.
And so what we really try to do is to look at it like a bell curve, and the vast majority of grantees do about the same 10 to 15 things in the sweet spot of that bell curve. But we want to leave the flexibility for the people that are working on the two tails
Mhm.
and to do that. So what we try to do is measure the bulk of the activity where the bulk of the grantees are, but not telling people they can't do something if it's a little out of the ordinary. And I'll give you an example. One year we got a grant from Alaska, and it was teaching children how to survive cold water drowning. So that's not an issue you worry about in Alabama, but it is an issue, a real issue in Alaska. And so that would be one of those tail type programs. Leave the flexibility to do it, but don't let the perfect be the enemy of the good on these things. So that's sort of how we try to balance those things.
Yeah, that's great. And I that visual is really helpful, the bell curve. And I thanks for diving into that a little bit more. You sort of half jokingly said it's a federal requirement to have program names that are long that then need an acronym. I'm gonna ask you about one of those because it's one that we hear about and is a has been around for a while, and that's the Rural Communities Opioid Response Program, often shortened to RCOR, silent P at the end. And a few organizations here in Kansas, and we highlighted it in our work, have received our core grants. And we know opioids and substance use are important challenges across the country. They can look different in different states. It's a challenge in urban and rural, but there are unique challenges for rural communities, and that's what our core is built to recognize. Can you tell me a little bit more about that program and maybe some key insights from that's been around for several years?
Sure. I really, yeah, I have to say, RCOR is one of those programs that have just been completely eye-opening for me. And we're so happy that we've had the chance to play at least, some role in the country's response to the opioid epidemic. And so the way it came about was we were starting to get more of those outreach grants I mentioned, people coming in to address this around 2015, 16. The Congress started putting some language in our budget about seeing what we could do to address this. And then during the first Trump administration, we had the idea to develop a budget proposal around it. And the idea was to take the same concept for outreach, but much more money and to target specifically on prevention, treatment, and recovery. And that was one of those years where the budget got passed late. And so this has never happened before. But so I think the president's budget got released in April, and we had our core in there. And the congressional budget was finally passed about a month later, and it took it right from the president's budget into the congressional budget, which hardly ever happens. But the timing was really fortuitous because it was still fresh in people's mind. And our thought was the same as we always have with our programs, which is, can we provide some startup funding to help people with good ideas have sort of a financial runway to take their ideas and bring them up to scale? The other dynamic that was at work with Hardcore is I think that typically when we have a public health emergency in this country, we've relied on state and block grants. You think about all of the major sort of public health funding in HHS, the vast majority of it is given out through the states. And there's a logic behind that. The states are closer to the action. They know where their issues are. And so the thought was they're better equipped to make those decisions about funding. And by and large, the initial funding for the opioid epidemic was done exactly that way with grants to SAMHSA, grants to the Centers for Disease Control and Prevention, to National Institute of Drug Abuse. Um, I think what we realized, though, was that treatment infrastructure in rural communities was so lacking relative to urban and suburban areas. Not that it was great in those areas either, but it was really lacking. And then you've got stigma and geographic isolation, and it was really sort of some real structural challenges. And it was clear that maybe those block grants were not the best way to get to rural communities. So they come down from the state capital to the community. But our design with Arcor was to go community up. And that's really the basis of the program. And because it was written broadly, we were able to start off with some planning grants and then some implementation grants. But we started to hear from people that there were unique issues in our core in the opioid space. For instance, meth was still an issue, and there were people who maybe started out getting addicted to opioids, and then as that got choked off, they were unfortunately switching to methamphetamine. We had other issues with neonatal abstinence syndrome. And because we had the flexibility, we could also do targeted grants just for those needs. We had research showing that if you go through childhood trauma, the greater likelihood would be that you were at risk of substance abuse later in your life. So we did a special initiative just around targeting child and adolescent health. And so that's been the beauty of our core is that the flexibility in being able to do that. But I think also what it was eye-opening for me is I defy anybody who has not been touched by this epidemic. Every family has. And so it may not be your immediate family member, but it's somebody you know, or it's a friend of yours, and somebody in their family is affected by this. So all of us are touched by this in some very meaningful ways. And so the chance to play a role in it and to help communities do it was great. And the grantee meetings, when we bring them all together, are unlike any meeting we've ever had. We've got law enforcement, we've got traditional healthcare providers, we've got people, a lot of people in recovery who are finding really meaningful work and working in this field as well. And they're the most self-affirming meetings I've ever been to in my life. People are so happy to support each other, to salute that they're in recovery and that they're on the way and that they're now helping their community. And the bonds between like law enforcement and community organizations has been really impressive to see.
Yeah, I in in a lot of ways, all the programs and are designed to be meaningful and important, and they are. It sounds like this is an especially meaningful program, and I think the example, and you noted it's one where you looked at the issue and had the flexibility to say this is not one that works top down or through the funding channels that work well for other approaches. So we're going to go bottom up. And I think it's a sometimes maybe we think it's either or, and it can be both and within the work of we need funding coming down through the states, and they are well positioned for some things. We need funding coming through other offices, other agencies, and we need that funding that can go straight to local communities. Another topic that I want to talk about, and you have such a deep resource of experience and insights into different programs and projects over your time. I'm sure there's lots of things you could talk about this next one, and that's workforce. It's the topic that often we come back to or comes up eventually in nearly all of these conversations. And I grew up in rural Western Kansas in a town called Ness City, and we were lucky to have an incredible physician. He was just wonderful. His name was Dr. MCS. If he happens to be listening, Dr. MCS, hello. He was really a fantastic physician for the whole community. But eventually, he retired and he moved away to be closer to family that now lived out of state. And it was a really big deal. It There was this real sense of loss across the community, even for those that maybe had got their care elsewhere. More recently, in contrast, I found out that my primary care provider is here in the Kansas City area is leaving and moving away, and I need to find a new one. And it was a simple letter. Uh, there was no there was no news about it. There was no agenda item at community meetings. It was not the topic of conversation in grocery stores. It just felt completely different. Like the same thing, a physician going away, felt very different in rural community. Uh, and I think about that experience and that challenge. Workforce is a challenge everywhere, but it those triumphs and those losses seem to be felt differently and uniquely in rural communities. And I think it's one example of there are particular challenges for rural workforce. So as a setup to ask you to think about. Tell me, how are you thinking about rural workforce? Because it seems so crucial to a lot of the things we want to do in rural health comes back to, do we have workforce there? How do we recruit, retain, and support them? How are you all thinking about workforce?
It's such a critical issue. It's one of those issues that has been around for as long as we've been talking about rural health. I suspect it will always be an issue we're talking about. And there's no one single way, I think, to address it. And whether we're talking about physicians or nurses or dentists or behavioral health specialists, it's a challenge. And so we've always wanted to do whatever we could in our programs to do it, but we never had a direct authority to really work on these issues until 2019. And it was interesting because we had funded a sort of an exploratory grant with the National Health Association to see if there was any way we could expand the number of rural residencies out there. I was lucky early in my career to do a detail in the Senate, working for Senator Kent Conrad of North Dakota. And one of the provisions that we got included in a big piece of legislation that year in 1997 was some flexibility around supporting residencies through Medicare, even though they established an overall cap on the number of residencies. But because of Senator Conrad's position on the Finance Committee, they were able to get some flexibility built into that allowed rural hospitals to still create residency programs. And a few took advantage of it, but it was largely not leveraged as much as it possibly could have. And so we had this initial grant with the National Health Association to look at it. And I think what we heard loud and clear was there was interest in building residencies, but it's an expensive proposition. You've got to get through the accreditation process, right? And then you've got to set up all the rotations, and you've got to do all that before you can get any support from Medicare or Medicaid to cover the actual training. And so, in talking with our congressional partners, we mentioned this, and they had an interest in doing something. And so, what we came up with was the Rural Residency Planning and Development Grants. And what we do here is we will fund entities to get through the accreditation process. We will work with them to make sure they identify hospitals that are eligible for Medicare support under that provision, or we work with them to see if their state Medicaid or other sources in the state would provide the actual training costs. And so this was appealing to the Congress because it wasn't necessarily funding a new sort of ongoing obligation in terms of residency. It was helping rural communities leverage provisions that were already there. And so it really worked out nice. And it's a really important consideration even beyond this example, because you can design a perfect program, but if it doesn't match an existing policy, there's no way to continue it. And you can also have a perfect policy, but if it doesn't work for programs, it's a non-starter. And this was one of those rare experiences for me where we had an opportunity to match program and policy in a very meaningful way. And then I have to credit our staff for this because they came up with the idea to put a really robust technical assistance part of this called Rural GME. And so they work with any applicant to make sure they're identifying the right hospitals, to see what their state's doing in Medicaid, and to make sure that we can get them accredited and then hand them off to Medicare or Medicaid to cover the actual training. And so over the years, we've created more than 600 residency spots in rural America. These are very small residencies at small rural hospitals, but we know from our research that if you do a rural training track, it's a five-fold greater likelihood that you're going to practice in a rural community. So is this going to solve the problem with rural physicians not going to rural communities? No. Can it be part of the solution? Absolutely.
Yeah, and I like the idea of and being thoughtful about policy and programs matching, and they need to work together. And there's a comment in chat, thanks, Linda, about growing up in Russell County, a county here in middle part of the state, and some of the what I think we could call rural realities, declining population, uh, that a lot of healthcare depends on social determinants. Those may look different in rural communities, and I want to hold that idea, that rural realities. And as we come back to this next question that I have for you, we've talked about the work you all do at FORP and the ways you're approaching these complex issues. And I want to now take a step back because FORP sits within HRSA and is part of this broader set of agencies and departments focused on health at the federal level. And earlier this year, I got to see you speak at an event here in Kansas. We got you to Kansas, and you were describing the history of federal policy efforts to improve rural health. And you showed this timeline of going back to the 1960s of all these different efforts, policy changes and new hospital designations, changes to payment models, and lots of things in between. And they were all, when they were developed, intended to improve health. Uh, but then you said something that I have thought about many times since, and you even put it on the top of the slide. You said one way to describe this history is a pattern of unintended consequences. Tell me more about that. What are some examples of this pattern of unintended consequences?
Well, and I had to say, I stole that term from my former boss, Wayne Myers, who is a longtime rural health advocate, who he always said our office should be named the Office of Unintended Consequences. And so I really lean very heavily on Wayne in terms of framing that argument. But I think it does describe what's happened. I think it gets back to the whole thing is it's a very diverse country. How do we design policies and programs that work for all that diversity? And it's hard. And so, like an example, I go back to 1965, the creation of Medicare and Medicaid, overall net positive. Everything's great. That helped rural communities just as much as it helped urban communities. It was also very expensive. And so by the 1980s, they realized they needed some form of cost containment. And so what they came up with was a way to bundle services and pay one price for that bundle of services. And it was called DRGs, or Diagnostic Resource Groups. And it was the way they paid for inpatient hospital services via Medicare. They tested it out in New Jersey. And of course, New Jersey looks a lot different than a lot of the rural areas we're talking about. And also, because it was paying a set price, what it meant was that if you have high volume, if you have a couple of cases that cost you more, you have many more that cost you a little less. It allows you to create a margin, positive margin. But if you're in a rural hospital and you have very few cases, and a couple of them end up being more costly, that's the difference between being in the red and being in the black. So that Medicare change, I think, created some real challenges for rural hospitals, and several hundred closed during the 1980s. And so there's your first unintended consequence in that regard. And then I think Congress is in a pattern of sort of saying, okay, well, now that we know that's a problem, what do we do? And so that's when you get sort of the alphabet soup of hospital designations, Medicare dependent, sole community, rural referral centers, eventually critical access hospitals. And they were all attempts to sort of get at the underlying issue that caused the unintended consequence in the first part. Um, but I think it was also true, and they decided to do the same thing for physician payment. And so that was in the early 1990s, and that affected rural communities in a very meaningful way. So that's a problem. A more recent example was when the ACA passed and they created the marketplace. Um, I think there were some challenges in terms of the insurance offerings being available as robustly in rural communities as they were in urban. And early on, that was a bit of a challenge. What I can say is that eventually the insurance market adjusted and we don't see those problems. But it had never been done before on a national level, so there was no way to know how it was going to play out. And sometimes you do got to let these policies play out a while. So in the case of the ACA, eventually the market corrected and we had fairly robust offerings in rural communities. So that's the one where I think over time the approach ended up working quite well. Another thing that happened in the late 1990s was we went from paying for home health, skilled nursing, ambulance in sort of open-ended ways. We moved them all towards what are essentially administered pricing systems, often fee schedules or prospective payment systems. And if you look in the early 1990s, most rural hospitals operated a home health agency. They operated their ambulance. They had a skilled nursing unit attached. And when we changed those payment mechanisms, we saw this disaggregation of those services moving out of the hospital because they no longer were profitable. And these were services I think those rural hospitals would have loved to have been able to keep, but they really couldn't because they were putting the whole hospital at risk in that regard. And so I think that's one we still haven't quite solved, that I think offers, maybe something we could work on for the future. And then the final one I'll mention is just when they created the Medicare graduate medical education payment system, it was very urban focused. In fact, if you look at a lot of the payments, follow I-95 from Boston down to down into the deep south, not the deep south, but really down through Atlanta. That's where the bulk of the Medicare supported residency programs were. And so it's taken a lot of work over the years to expand that residency training to other areas of the country. So none of these things were done because people like didn't care about rural. It's just the difficulty of threading that needle of policy that works equally well for both rural and urban.
Yeah, yeah, and it's that challenge of, you mentioned earlier, if you design a program that works for 80% of the population, give or take, seems like that would be good. Like that's a if we're playing if we're playing most sports, if you're shooting 80% from from the 3-point line, you're the best player that's ever played. But if you're in that 20%, it doesn't work so well. I I want to come back to this idea of rural realities and maybe how we chip away at trying to avoid that. But I don't want to lose that there likely are. You gave the examples of unintended negative consequences. And that doesn't mean that there aren't positive examples of federal policy change that have worked well for rural communities and maybe done that well. So, any examples when we, from your perspective, tried to make a federal policy change or a big program change, and we threaded that needle that you talked about, and we did it well.
Sure. I think one of the one I've always point to is the creation of what are called swing beds. And this is a provision that allows a rural hospital that has an acute care bed. And typically in a rural hospital, you don't have a lot of inpatient volume. So sometimes those beds are not occupied. And so the Congress came up with this idea of a swing bed where you could, based on need, switch it from acute to skilled nursing care. And in reality, in a rural hospital, it's the same staff are taking care, whether you're in a skilled status or you're an acute patient. And it was a recognition that you needed that sort of flexibility in there from a staffing standpoint. And then also, it doesn't make any sense for that patient who is no longer acute and now just needs perhaps some rehab care to have to then get shipped off somewhere away from home when they could just be changed their classification and cared for in that same small rural hospital. And so that has been, I think, one of the most elegant solutions I've seen because it was one that was like, what's the reality in rural communities? And how do we make the resources we have work better? And so I would point to that one 100%. I would also say that the creation of the critical access hospital designation and then an accompanying grant program called the Rural Hospital Flexibility Grant Program that goes to states to work with those CHs is another really good example of designing something that I think has stood the test of time. So the states get a role in sort of supporting those critical access hospitals. I was just with all of our flex grantees yesterday, and they're doing a great job in terms of encouraging them to focus on quality improvement and performance improvement. So that one works really well. And I guess the other one I would mention is, well, two more. If you think back to nurse practitioners, physician assistants, there was a time when they were not paid directly. Initially through the Rural Health Clinic Act, and then through federally qualified health centers, there was provisions that allowed them to bill directly for their services, and that ended up being a test case for it. So that started in the 70s, and then by 1997, people realized, this is not just a rural thing. This should help the whole country, and so because they had this body of evidence tested in rural and underserved, they then expanded that reimbursement to all of the country for physician assistants and nurse practitioners. And more recently, for years, people have been saying, why can't we do the same thing with marriage and family therapists and licensed professional counselors? When you think about the dearth of mental health providers out there, but not just in rural areas, but urban as well, why not let those folks bill Medicare directly as well? And we have a new study out showing that the rural enrollment, this is from the University of Washington, they've done great work on it, The rural enrollment of marriage and family therapists and licensed professional counselors is significantly outpacing that in urban. And so you can train these folks faster, you can deploy them into rural communities. So that's another good example. And the final one I'd mention is same bill, 2020, the Consolidated Appropriations Act of 2021, that authorized payment for those two provider types, also created the latest new rural hospital designation, the rural emergency hospital designation. And what it basically says, if you want to keep emergency care and outpatient, you can become an REH. You can no longer provide acute care services. And it was never meant as a cure-all for rural hospital closing, but if it's between closing the hospital and having nothing, or closing the hospital and having a rural emergency hospital, it's a lifeline for rural communities. And they make a significant facility payment to that hospital for the loss of those inpatient dollars. So, not that it's the answer to all things, but it's an example of where we created something specifically tailored to rural, and there's 51 of them now. I don't know that number will grow dramatically over the next, 10 years under the current regulations. But for those 51 communities, it's been super important.
Yeah, and we have some RHs here in Kansas. I Thanks for the examples of success, and I think the thing I'm hearing in both the pattern of unintended consequences when maybe didn't quite thread that needle, and when we've done it well, is this idea, which is easy in practice or easy in theory, but maybe hard in practice, is how do we take rural realities into account on the front end, not after, and then say, okay, now how do we adjust it to make it work, but on the front end. And I think everyone listening in today likely has some role in supporting rural health, otherwise they wouldn't be here. But they might not be in a position to shape federal programs or federal policy. But that doesn't mean they can't shape work in their region, in their state, in their organization. And so if we go to that idea, taking rural realities into account on the front end, what are some ways that you can think to suggest or recommend that we can collectively do that well, regardless of where we sit? How do we better take rural realities into account on the front end before we pass policies and enact programs and launch initiatives?
Yeah, I mean, it gets at the core of what we talked about throughout this engagement, Wyatt. I think, there are fewer of us in rural America, so our voice has to be louder. And so anything folks can do to engage with policymakers at local, state, and federal levels is really important to make sure that people understand their unique reality. So whether you do that individually or through an association that you're a part of, your voice is really important. I think that working with local philanthropy can be a real plus in that regard as well. So those are two areas. The other thing I would say is, maybe not so much about the community level, but more about like how we inform ourselves better at the national and state level. Is we don't do a consistent job when we fund research of requiring rural urban cuts in the data. And the problem with that is because our numbers are so small relative to urban, you can miss important trends. We talked about the RCOR program earlier, and you may have seen earlier this year that, great news nationally that the overdose death rate is declining. After years of rising, it turned a bit of a corner, right? That's not as true in rural communities as it was in urban. And our first national studies that were released only talked about the national level. Thankfully, there's a CDC now has an Office of Rural Health. And so Diane Hall and Macarena Garcia have done really great work about encouraging more rural urban cuts. And they have in development a new version of an analysis of that overdose death rate by rural, urban, and by census region. And that's going to be in their MMWR, the Morbidity Mortality Weekly Report. It's in clearance right now. But, so what this shows us is that yes, things are getting better, but they're not necessarily getting better as fast in rural. So before we declare victory, let's make sure we have all the data we need. And that can happen in just about any issue. And I would suspect it's true at the state level too. Like if you're talking about, any sort of access to care or chronic disease burden. What does it look like in Western Kansas compared to Kansas as a whole, right? What does it look like in the Deep South compared to the country as a whole? What does it look like for tribal populations? If you took the tribal populations and just compare them to urban, overall national rates, you'd see significant disparities. But we tend to sort of sometimes just look at this as a national figure, and so much gets lost. The same thing along the U.S.-Mexico border. If you took the 100 miles north of the border and treated it as one state, they'd have among the worst health indicators in the country. But you wouldn't know that if you don't disaggregate the data. So that would be one. The other thing I think is just, I think rural people can do a really good job of telling policymakers, and I'm not coining this term, somebody else did, the tyranny of numbers. It always works against rural. We always have lower volume, higher fixed costs, and that makes delivering any service harder. And so policymakers need to understand that on the front end. And then one final plug, because this article really informed me greatly. Jan Probst and her colleagues at the University of South Carolina did a great article a number of years ago called Structural Urbanism. And if you want to really encapsulate the urban-rural dynamic of policymaking, I think that journal article, which I think appeared in Health Affairs, I'm not sure, was just a fantastic way to frame the argument.
Yeah, thanks for all those thoughts, and it's a good reminder to me that we're going to have a recap for this conversation. We will share some resources, and that's one we can look to potentially add to your to the recap page. So folks that want to come back and re-listen or access those resources. I've got so many notes here and things I want to remember and phrases. The tyranny of numbers is one that uh, that will stick with me. And the other thing that I think you didn't explicitly mention, but I think is embedded in your office and perhaps is another way we can do this work is to not let rural, while we can have dedicated rural focused work, not let it stay in its silo, to use the common term, but let the rural question show up outside of dedicated rural spaces, and that's doing showing up in our data collection, showing up in our overall initiative, asking that fundamental question: does this look the same way in rural places? Because by default, it may be designed with sort of an urban bias in mind, unintentionally or intentionally, because that's where most of the people are. But if we can ask that real question, we can maybe design better programs. Before we get towards our last question, we're running out of coffee, we're running out of time. I want to invite people. Stick around for this last question, but also give us your feedback. We would love to hear what you thought of our conversation today and suggestions for future coffee hour topics or future guests. So if you've got someone that you're like, this person would be great, or this topic I want you to discuss, now's your chance. So Michelle, dropped that in chat. So please give us those suggestions. I you mentioned at the beginning, one of the key things in the evolution of your work was creating a clearinghouse for all the resources, and that clearinghouse became Rural Health Information Hub, which is a fantastic resource that I hope folks know about. If folks don't know about Rural Health Information Hub, uh, what is Rural Health Information Hub? What can they find there? And what are some other suggestions for resources for those that are listening in that said, I heard a lot of things. I want to learn more, or I want to dig in and investigate. What are some suggested resources folks could explore?
Well, sure. I think it might be easier to explain what RJ Hub doesn't have than what it does have, because it has so evolved beautifully over the years. I have to give Chris Sandy a ton of credit because every time we come to her with a crazy idea, she's like, "Let me think about that." And so it started out as just a general information where this is pre-internet. You could call up a librarian and they would research a question for you. But Chris and her staff have done a great job of sort of cataloging just about every rural issue you can imagine. And they have topic guides and information pages. They've branched into toolkits where they've looked at some of the things we've done with our grants, and those that are particularly innovative, they are in the Models and Innovations Hub. They also sponsor webinars. They've just been a fantastic resource over the years. So I would encourage anybody to sort of dive around, look around there, but they'll also respond to your emails. So say you want to know something about ag and mental health, they'll research that and they'll get back to you with information. So it's not just a static page, but it's an interactive resource for rural communities. And so they've done a great job. One of the other things, it's also, and they're based at the University of North Dakota, also based at the University of North Dakota, is the Rural Research Gateway. We wanted to make sure that the research we funded, you didn't have to just go to a journal to find it. So the Research Gateway has access not just to all the studies we fund, but also information about the researchers themselves, their emails. They love to hear from folks. And so it's a way to engage the researchers about their research. And so that's an important resource. And I'd be remiss if I didn't also mention, the HRSA website. We have a ton of data, that available for all of the HRSA programs. Our webpage has all information about our grant programs. You can find out information about health professional shortage areas and medically underserved areas. So really, it's a wealth of resources there as well. And then I'll put in a plug. Next Tuesday, we're doing a webinar where our colleagues at the Office of Secretary are going to walk people through a new dashboard they have looking at rural hospital viability. And then the University of North Carolina folks are going to walk through their financial distress index. So just Google that and sign up for it. I think it'll be a really interesting webinar.
Yeah, thanks for all those resources. And uh, I the Rural Health Information Hub has a ton of stuff. Like you said, it's maybe better ask what's not on there. One of my favorite things on Rural Health Information Hub is there's a place where it's called the Am I Rural tool, and you can enter your address and see whether you're rural across all these different definitions in it. I think it can be very helpful when applying to grants. I find it very insightful for the complexity of rural definitions, and that's a good um, uh, example of the broader complexity of rural work. Uh, there's a couple comments here in chat that folks put in the end. Thank you both, Linda and Michelle, for comments, and another one coming in, some good discussion. And one of the things that I saw in there in the last couple minutes before we hop off, saw the challenge of those going back to the discussion about home health and nursing home. Those that fall maybe don't, those services are lost and experience that they end up relying or needing EMS services. We haven't talked a lot about EMS, but they are certainly a key piece of this rural health workforce and delivering healthcare. Any examples or things that people could maybe explore EMS wise that you all have been working on?
Into the transformation program. I think just, looking at it very informally, I think I saw about 10 or 11 states that are really looking at unique ways to leverage EMS, including some that are looking at ways to pay for ambulance runs, even if they don't result in a transport to the hospital. That's one of the real conundrums, right? The way ambulances are funded is you only get paid if you transport. And yet sometimes it's just a matter of stabilizing. And so I'm really interested in what the states learn from testing out a new way to pay for ambulances and whether that then can yield a bigger discussion about should we be rethinking the entire way that we pay for ambulance and EMS services in this country, because the way we're doing it doesn't really work in low volume areas that have to cover huge geographic spaces.
Yeah, and that's a great way to come back to this topic we've been digging away at for the last 59 minutes. How do we better take rural realities into account? And I thank you so much for spending an hour telling us about how you're doing that at the Federal Office of Rural Health Policy. We could have spent another hour talking about it. But I really appreciate your time and all the discussion. And thank you all for being here. And please come back next month, same time and place. We look forward to seeing you then. And thanks again for the discussion and the great conversation, Tom. We really appreciate it.
Thank you as well. Take care.
Take care, everyone. Bye bye.